Hi, my name is Amanda Shaw.
And I'm Erin Phillips.
Our topic is on the Surviving Sepsis campaign bundles updated in 2012.
What is sepsis? Sepsis is a life-threatening illness and complication resulting from a confirmed or suspected infection causing a systemic inflammatory response in the body. It can lead to severe sepsis and septic shock. Severe sepsis is organ-induced organ dysfunction or tissue hypoperfusion. Septic shock is severe sepsis along with hypotension unresponsive to fluid resuscitation. Shock can lead to multiple organ dysfunction, syndrome, and even death.
So what is a bundle? A bundle is a group of recommendations that improve outcomes more efficiently as a unit as opposed to being given separately. The sepsis care bundles are early goal-directed therapy involving the rapid administrations of fluid and vasopressors. They include interventions that should be implemented within 3 and within 6 hours of triage.
Okay, so I'm going to talk about steps to be implemented within 3 hours. The first step is to measure lactate level. Hyperlactatemia is typically present in patients with severe sepsis or septic shock. Obtaining a lactate level is essential in identifying tissue hypoperfusion in patients who are not yet hypotensive but who are at risk for septic shock. All patients with elevated lactate above 4 millimoles per liter enter the early goal-directed therapy portion of the 6-hour septic shock bundle, regardless of their blood pressure. Second step is to obtain 2 sets of blood cultures before administering antibiotics if obtaining the cultures does not cause more than a 45-minute delay in the start of antimicrobial therapy. This is because the incidence of sepsis and bacteremia has been increasing in the past 2 decades. Obtaining blood cultures confirms infection and helps to identify the responsible pathogens. If the same organism is recovered from both cultures, the likelihood that the organism is causing the severe sepsis is enhanced. The third step is to give broad-spectrum antibiotics that cover all likely pathogens, including bacterial, fungal, and viral pathogens, and that enter into tissues at sufficient concentrations within the first hour of recognition of septic shock and severe sepsis without septic shock. The antimicrobial regimen should be reassessed daily for potential reduction of resistance and toxicity. This is done because patients with severe sepsis and septic shock have little margin for error in their choice of therapy. The most appropriate antimicrobial agent that covers the pathogen and that is safe and cost-effective should be selected. This will also reduce the likelihood that the patient will develop superinfection with other pathogenic or resistant organisms. The fourth step to be given within 3 hours is to give 3 milliliters per kilogram of crystalloids for hypotension or lactate greater than or equal to 4 millimoles per liter. Patients with sepsis-induced tissue hypoperfusion with suspected hypovolemia should attain at least 30 milliliters per kilogram of crystalloids, part of which may be albumin equivalent. Patients who are hypotensive or have a lactate greater than 4 require IV fluids to expand their circulating volume and effectively restore perfusion pressure. Crystalloids are recommended over colloids because there's no clear benefit of colloids over crystalloids, and colloid solutions are also have a greater expense associated with them.
So I'm going to talk about the steps that are to be completed within a 6-hour bundle. And the first step is applying vasopressors for hypotension that does not react to fluid resuscitation to maintain a mean arterial pressure of 65 millimeters mercury or greater. When an appropriate fluid challenge fails to restore an adequate arterial pressure and organ perfusion, therapy with vasopressor agents should be started. Vasopressor therapy is required to sustain life and maintain perfusion in the face of life-threatening hypotension, even when hypovolemia has not yet been resolved. The second step is that if arterial hypertension persists in spite of volume resuscitation, known as septic shock, or initial lactate levels of 4 millimoles per liter or greater, you need to measure central venous pressure and central venous oxygen saturation. And it's because these endpoints help clinicians adjust cardiac preload, contractility, and afterload to balance systemic oxygen delivery with demand. Maximizing mixed or central venous oxygen saturation increases survival, and a CVP needs to be maintained at greater than or equal to 8 millimeters mercury. and central venous oxygen should be maintained at 70% or greater. The third step is to repeat measurement of lactate if initial measurement was above normal.
Okay, so the Surviving Sepsis campaign has other recommendations besides just the bundles for patients that are in septic shock, and we focused on some grade 1 recommendations. The grade system classifies it as either grade 1 or grade 2, grade 1 being strong and grade 2 being weak based on the degree of confidence on the assessment. So a few grade 1 recommendations that we have are to provide routine screening of likely infected patients for severe sepsis to increase early intervention. Early identification improves outcomes and reduces mortality. Norepinephrine is the first choice vasopressor. Norepinephrine increases the mean arterial pressure with little change in heart rate and less increase in stroke volume compared with dopamine. It's more potent than dopamine and may be more effective at reducing hypotension in patients with septic shock.
Some other grade 1 recommendations include an upper limit for plateau pressures and passively inflated lungs to be 30 centimeters H2O or less. Another is that positive end expiratory pressure should be administered to avoid alveolar collapse. Mechanically ventilated sepsis patients should have the head of the bed elevated 35 to 45 degrees to prevent aspiration and development of ventilator-assisted pneumonia. Weaning protocols need to be placed for mechanically ventilated patients with severe sepsis. And the routine use of pulmonary artery catheters are not recommended for patients with sepsis-induced ARDS. Continuous or intermittent sedation should be reduced in mechanically ventilated sepsis patients. And the use of blood glucose management protocol in ICU patients should be implemented with severe sepsis cases. And stress ulcer prophylaxis is recommended for patients with severe sepsis or septic shock who have bleeding risk factors.
So in summary, just the significant updates that have applied to the 2012 guidelines from the 2008 guidelines are quantitative resuscitation with precise targets. Crystalloids are the preferred fluid for volume resuscitation. The use of norepinephrine is preferred for vasoconstriction. Lactate clearance was added as an indicator of tissue hypoperfusion. They've decreased the utilization of corticosteroids and removed activated protein C from the 2012 guidelines.
On that note, we would like to conclude that research has shown that compliance to sepsis bundle has increased in recent years, resulting in a decreased mortality. That's all.